I'm John M. Thompson. I'm a clinical professor of neurological surgery at the University of South Florida Medical School in Tampa, Florida. And I have the honor today to interview Dr. John Holter, who has contributed a great deal to our field of neurological surgery. John and I are attending the 62nd annual meeting of the American Association of Neurological Surgeons here in San Diego, California on April the 10th, 1994. Now, John has contributed far more to neurological surgery than I ever have, in spite of the fact that he is not a neurological surgeon. And in order to understand John's contributions to the field of neurological surgery and to the problem of hydrocephalus, I think it's appropriate to at least briefly discuss something about the history of hydrocephalus. Hydrocephalus has been known to exist for thousands of years, and physicians have been very frustrated in trying to help these unfortunate victims of hydrocephalus. Up until very recently, and actually until John became interested in hydrocephalus, the vast majority of these people died in the first few years of life. Occasionally, a child or a baby would develop arrested hydrocephalus, where the head would grow abnormally rapidly for a while, and then there seemed to develop a balance between the production and absorption of cerebrospinal fluid, and we had a condition of arrested hydrocephalus. But unfortunately, that did not happen very often. This particular photograph shows what happened in most cases of hydrocephalus. I started practice in St. Petersburg, Florida in August of 1956, and I was on the staff of a Catholic hospital. I was never actually asked to see this baby formally on consultation, since the child had been born over a year before I started practice. One of the nurses told me about this baby. The mother had abandoned the baby after delivery in the hospital, as the child was born with hydrocephalus. The nuns in the hospital felt very sorry for the baby, and so the baby received excellent nursing care with no decubiti on the head. But one can look at this photograph and see how small the hands and feet are and how huge the head is, and yet the baby is sucking one of the fingers, and you see a stuffed animal in the background. The head was actually transilluminated. I had a flashlight or a pen light, and at night put the pen light up against the head, and the entire head transilluminated, what we then referred to as candling. And eventually the head ruptured, the cerebrospinal fluid drained out. Obviously the child developed meningitis and died, and that was the natural history of hydrocephalus. Physicians tried all types of ways to treat this condition. The basic pathophysiological research was conducted by Dr. Walter Dandy and Dr. Blackfan, who was a pediatric resident at the Johns Hopkins Hospital. I feel that it should be an inspiration to all neurosurgical residents to realize that Dr. Walter Dandy did this basic research when he was still a resident. In fact, Dr. William Halstead, who was chief of surgery at the Johns Hopkins Hospital, said that most people never make more than one major contribution to medicine, and that Dr. Walter Dandy, as about a third-year resident, had already made that great contribution, and he probably would never contribute very much again. Fortunately, Dr. William Halstead was wrong, because when Dr. Walter Dandy was a senior resident, he described ventriculography. And this involved, initially in babies, putting a needle through the anterior fontanelle, draining out ventricular fluid and replacing it with air. And so for the first time in the history of mankind, it was possible to demonstrate the size of ventricles in the head deliberately. Prior to that time, there was an occasional case where a person was hit by a streetcar or other vehicles and air went into the cavities, but not deliberately so. So during Dr. Walter Dandy's 8-year surgical residency, he described the basic pathophysiology of hydrocephalus and also a diagnostic test to indicate the size of the ventricles. He obviously was interested in trying to help the unfortunate people with hydrocephalus, and he devised some operations to try to help these people. And he described choroid plexectomy, where initially he went in by surgery, open operation, and removed the choroid plexi, where he had determined that the cerebrospinal fluid was produced. And then later he borrowed a cystoscope from Dr. Howard Kelly, who was chief of gynecology at Hopkins, and then did a scope procedure to remove the choroid plexi. Dandy was obviously far ahead of his time because he was using the scopes in major surgery, very much like cholecystectomy is done now, and yet was decades ahead of his time. But unfortunately, the operations by Dr. Walter Dandy were not very successful. Even though the choroid plexi were removed, the children's head continued to enlarge, and most of them eventually died. I'm going to hold up a diagram of 26 operations performed in the hope of alleviating or helping children with hydrocephalus. And the first 24 were largely failures. It is amazing how ingenious many of the physicians who devised these operations were. A German surgeon felt that if he could only divert the cerebrospinal fluid back into the bloodstream as nature normally did it, that this would cure the condition. He took veins from the legs that had vowels in them and then inserted the vein from the ventricle into the jugular vein with the valve turned so the fluid would go in one direction, a one-directional valve. Unfortunately, the operation was not successful. Dr. William Sharp, a neurological surgeon in New York, in about 1917, about the same time Walter Dandy was working on choroid plexectomy, he devised an operation where he took 7 threads and passed them into the ventricle, brought them through the brain and below the temporalis muscle, hoping that these 7 threads would act as wicks, allowing the ventricular fluid to flow beneath the temporalis muscle where he hoped the fluid would be absorbed. Unfortunately, the operation did not help very long. The fluid was shunted into many cavities and many spaces. Operations were done to try to shunt the fluid into the superior sagittal sinus, into the transverse sinus, into mastoid air cells where the fluid would go through the mastoid air cells, eventually in the middle ear, and run down the eustachian tubes, and the person would swallow their own ventricular fluid. Obviously, there was danger of infection. There were operations trying to shunt the fluid into the pleural space, into the peritoneal space, even into fallopian tubes where the cerebrospinal fluid would run retrograde into the fallopian tubes, up the fimbria, and into the peritoneal cavity, trying to prevent the reaction, foreign body reaction, where the omentum would wrap around the tubes. But again, this did not help very much. I took my residency in neurological surgery at the University of Michigan in Ann Arbor, Michigan. And I well recall when I was a resident there that I was asked to operate on a tiny baby, And Dr. Eddie Kahn, who was chief of neurological surgery, suggested I explore the fourth ventricle, and which I did, and then pass a tiny red rubber catheter up the aqueduct of Sylvius in the hopes that there might be a thin membrane occluding the aqueduct of Sylvius. Fortunately, in this particular baby, as I passed the small rubber catheter from the fourth ventricle up the aqueduct, I did encounter a membrane. I was able to rupture the membrane without damaging the midbrain, and the operation was quite successful in curing the infant of hydrocephalus. That was, however, one of our few successful operations for hydrocephalus. The favorite operation when I was at the University of Michigan is what we called the Matson procedure, named after Donald Matson, who was chief of neurological surgery at the Children's Hospital in Boston. We would do a dye test in which we would inject the dye through the fontanelle into the ventricular fluid, and then within 30 minutes would do a lumbar puncture to see if the dye was in the lumbar cerebral spinal fluid. If there was dye there, we considered that we were dealing with communicating hydrocephalus, and we thought then that it was very important to differentiate between communicating hydrocephalus and non-communicating hydrocephalus. If there was dye in the lumbar subarachnoid fluid, we would do a procedure in which we would insert a small polyethylene catheter into the lumbar subarachnoid space and then feed the small polyethylene catheter into the retroperitoneal space, take out a kidney, do a nephrectomy, and pass the end of the polyethylene tube into the ureter. So basically the baby would void or pass cerebral spinal fluid out with the urine. This operation worked fairly well in male babies because male babies have a longer ureter, rather a longer urethra. But unfortunately, female babies had very short urethras, and they were much more apt to get bladder infections. Every time they would get a bladder infection, they also would get meningitis, and many of them died with meningitis. The other problem with this operation was that there is sodium and chloride in the cerebral spinal fluid, and so these babies were constantly losing salt every time they voided. Then if they developed diarrhea, as babies tend to do, they lost even more salt. Many of the babies that we did surgery on came from the upper part of Michigan, some from the Upper Peninsula. They would be sent down to Ann Arbor, usually by ground transportation, and frequently would arrive dead from electrolyte imbalance. So the operation was frustrating. I was invited to stay on the faculty of the University of Michigan by Dr. Eddie Kahn and by Dr. Richard Snyder, and I enjoyed my faculty association at the University of Michigan, but then I decided to enter private practice in St. Petersburg, Florida, because I had been born in Tampa, Florida, and it was not far from my home. At that time, St. Petersburg was the headquarters of the Florida Crippled Children Commission. In fact, there was only one district in Florida with the headquarters in St. Petersburg, and so when I started practice in August 1956 in St. Petersburg, I found that I was the pediatric neurosurgeon for the entire state of Florida. I got most of the pediatric neurosurgery and practically all of the charity pediatric neurosurgery, and a great deal of the pediatric neurosurgery was charity at that time. So I had the responsibility of operating upon a large number of babies with hydrocephalus. I did the type of operations that I had been trained at the University of Michigan, and I was very frustrated with my results. Fortunately, early in 1957, I read in the St. Petersburg Times, our local newspaper, that Mr. and Mrs. Holter, who lived in St. Petersburg, were very proud of their son, John Holter, who had developed a competent valve for hydrocephalus in Pennsylvania. I was so frustrated that I looked up the phone number of Mr. and Mrs. Holter in St. Petersburg, called them, and I said, how do I get in touch with your son, and how do I get some of these vowels? They told me how to contact John, and I contacted him. I think it was about January or February of 1957, and John told me that the vowels would only be released to people who came up and observed operations in Philadelphia at the Philadelphia Children's Hospital. And so I made arrangements to go up to Philadelphia. I saw 2 operations on hydrocephalic babies where Holter vowels were inserted. John met me at the hospital and took me out to his laboratory and plant where the vowels were made, and I then arranged to secure vowels from John Holter. As far as I know, I was the first neurosurgeon south of Philadelphia ever to use Holter vowels. And it made a great deal of difference in my treatment of hydrocephalus. It was almost a difference between night and day. Finally, I had something to offer these unfortunate children with progressively enlarging brains or progressively enlarging heads with thinning of the brains. And it was a dramatic improvement, and there was much less frustration in dealing with this type of case. Now, John, I would like to ask you how you, a non-neurosurgeon, was able to accomplish something that brilliant neurosurgeons before you were not able to accomplish. And you know, you had no background in neurological surgery, and yet in a short period of time you succeeded when so many neurological surgeons had failed.
Well, I suppose the motivation of my own very sick baby, who was born in November of 1955 with Arnold-Chiari syndrome, as you well know, involved the hydrocephalus, spina bifida, and other malformations. And when, after many procedures to try to correct the back, he had a repair job. He had 2 cases of meningitis, and then they were tapping the head to remove the cerebrospinal fluid, and they used 2 shunt simple tubing from the ventricular system to the peritoneal cavity, and they failed within 10 days or 2 weeks. And I was getting more frustrated with the lack of progress in helping him. It seemed to me that there should be some other way to draining this system off. And I have had no experience in medicine other than Band-Aids, that sort of thing. And I realized that it couldn't have an open drain into the brain. No, I've been aware of infection problems, having even been a few months in the hospital with Casey in those times. And there were a lot of children in that hospital that had similar kinds of problems from various reasons, traumatic and diseases and acquired ones and congenital problems. And I was finally, after a lot of persuasion, able to talk to one of the neurosurgeons, and I said, there must be some way to drain that. He said, oh yes, there's lots of ways of draining it, but none of them are very good, much to the results of the diagram you just exhibited here. And he said, what we need is a one-way valve. And they explained that many groups have worked on this, and one of them was the Johnson Foundation in Philadelphia, part of Johnson & Johnson. And that they had made some valves that they had tried. He and Dr. Nelson in Cleveland at Western Reserve had proved to themselves that it was a practical approach, but they needed a valve that would really be competent to prevent backflow due to the fact this drainage was into the venous system, and blood backing up into that catheter could clot and destroy the operation in very short order. So I immediately had an idea of how to do that, and I went home that night and constructed a little demonstration model of, in fact, by the way, what prompted this was I saw a nurse irrigating an IV, in the arm of a patient. And I thought, well, if that needle puncture would close spontaneously on that natural rubber, maybe it would close on a little slit. And I went back home and started cutting little slits in rubber and natural latex rubber and different kinds of plastics. And I made a plastic demonstration model to show that it was would resist backflow, reflux, and it would pass. I have a picture here of the very earliest valve system. Now the upper one is the demonstration model. It doesn't show up very well against that dark background, unfortunately, but that was polyethylene and polyvinyl chloride tubing glued together, and with a valve here and here, and by compressing it in the midsection, you would displace fluid downstream, and it would, but it would withstand the reflux very well. Of course, when I demonstrated that to the surgeons there at the hospital, they were all enthused, and they all thought this was a marvelous idea, and they wanted to encourage me to go ahead with it. But of course, they had to make it smaller. As you could see, it's pretty large, and make it tolerate body chemistry, and I could understand that pretty well. They said it had to go through an autoclave, so I said, what's an autoclave? I had no idea. Located myself in the medical world very well with that. At any rate, after they finished laughing about it and explained what the autoclave was, I started out hunting for a high temperature plastic that would, I'll lay this down for a moment, a high temperature plastic that would tolerate the temperatures and the autoclave and tolerate body chemistry. And just going through the phone books through all the chemical houses and rubber suppliers and so on, I finally located someone who suggested using silastic of this type of for this type of a device. I had never heard of it, and at that time was really not much more than a laboratory curiosity, silastic. It was used in bomb bay doors of the high altitude bombers, so that because rubber at these extremely low temperatures would get brittle and crack and break away, where the silicone did not. And it was such a complex structure that the chemists, where they described this to me, said that they couldn't believe that it would migrate in the body, and the body would tolerate it pretty well. And they were right, fortunately. So they had someone nearby make the first of the little tiny condom-shaped pieces. When I made a little slit in the side of them, and I made the little metal parts and the connector tube, which we have right here in this picture again. And this second view, here's the inlet end, was put into the ventricular end of it here. You can point out that angled part is placed into the ventricles, and then the fluid would run down through the valve itself, and then on down to the atrium. At that time was used as an atrial shunt, a VA shunt. In fact, they were called VJ shunts because they went into the jugular vein. But I didn't know how long it was going to take for me to find the material. Actually, it was 3 weeks. But during that period, not knowing, I asked the doctors there to use one of the existing spring and ball type valves. It was kind of a classic, kind of a pressure type of valve that had been made by Johnson Foundation. I think it was very crudely made, but I adjusted the best I could, and they put that in my boy, Casey, and when he was about 3 or 4 months old. Unfortunately, I think the distal catheter was polyethylene, and it probably touched the SA node and caused a 30-minute cardiac arrest. And shortly after that episode, I had this valve prepared, but he was not longer in any condition for further surgery at that time. He was in pretty delicate balance. He's in an oxygen tent and pretty precarious state. So another child was done at Children's Hospital, and then Casey was the second one done, and both performed very well. And that valve continued to function very well for till the time when it had to be removed from the atrium and put into the peritoneal cavity. Due to growth, the lengthening became a problem because he lived, and this is one of the problems of those early valves was that they did live and the growth became a factor in their future. So that was the first of the valves that was done. Now my, as I say, experience in medicine was nil, but it worked. Does that explain it pretty well?
Yes, you mentioned there was like a small elastic rubber condom, and there was actually one on each side in each metal housing. Isn't
Yes,
that correct?
that's correct.
And then there was a piece, this just shows red rubber. Later, this also was elastic rubber, and with this type of valve, it was possible to compress the elastic rubber in between and actually pump the valves. This was a great advantage to neurological surgeons in that, as John mentioned, babies grow, and frequently they outgrow the valve. And occasionally choroid plexi would get up along the ventricular catheter, and by pumping the elastic tube in between the two nipple valves, it was possible to tell whether the ventricular end was obstructed, because if the ventricular end was obstructed, when you pressed here, you pushed out the cerebrospinal fluid, and the connecting silicone rubber tube remained compressed. It didn't fill out with more cerebrospinal fluid. While if the obstruction was distal, for instance, a baby outgrew it and there was a clot in the internal jugular vein plugging it up, one would press it and it would be firm to pressure. And that helped us differentiate whether the obstruction, which end needed to be revised. So I thought it was really very ingenious that there was a double nipple type valve. I tried to explain it to some parents when I was doing the operation, to say it was sort of like a baby bottle, a plastic baby bottle with a rubber nipple with a slit in the nipple. And if you squeeze the plastic baby bottle, one could force the milk through the slit in the nipple and squirt it out. And then when you stop squeezing, the slit would close and no more fluid came out. At least that's how I would try to explain it to parents. But I thought it was really very ingenious, and the valves came in several different pressure gradients. Do you wish to explain that, John?
Yes. In the beginning, I was told to make them only the minimum opening pressure, but we soon found that the surgeons found that it was necessary to have some higher pressure gradients on it for other conditions. And we made a longer slit so that it opened easier, and a shorter slit to make it more difficult to open and cause a higher pressure gradient. And this was a little line drawing sketch of the device. That little helix on here is not a spring, it's just a coiled wire to prevent a collapse of the little internal valve if someone accidentally put a syringe to try to irrigate the thing before placement. But you can see here is the little slit valve here is that nipple-like shaped thing, or a condom-shaped piece that has a slit in it, and there's one on each end, and that shows how that was constructed. This is another view of an exploded picture of the valve assembly itself. You can see very clearly in this photograph, this was taken probably around 1957 or 1958. It was, but it shows pretty clearly the various components, perhaps better than that line drawing would show. I guess you can close in on that. Then I'm a little bit embarrassed with Dr. Thompson said that you said the visited my laboratory and workshop, and all my laboratory was a pretty insignificant little place, probably about half the size of this room, and the shop was very small with a few employees, but we were just struggling to get along. And in fact, before I even had that shop, I was worked in my own home, and this is a picture of me working on the original little test rack. It has 4 pairs of vertical tubes of water. It's like 4 manometers, and I would fill them with water and put the valve connecting between the higher one and the lower one in each case, so it could test 4 valves at one time. And then I would evaluate the pressure gradient of each valve so that it would have some idea what pressure type it was. I wasn't as able to calculate as scientifically as maybe I should have. In fact, had I known that Dr. Pudens was working on this seriously in California, but doing it in a very scientific manner and with dogs, I would have probably hustled Casey into a plane and hopped out to California to have him work on my boy, but I didn't know about his work until maybe 2 years later, that the work he'd been doing at the Huntington Laboratory. Here I am working in my little garage on a little lathe, making the little parts for the valve. And then,
John, I don't think you should apologize for your laboratory, because I've seen Thomas Edison's laboratory in Fort Myers, Florida, and as I recall, he also had a rather small laboratory and worked mainly alone. He was not part of a large research team, and yet we obviously owe a great deal to Thomas Edison. He did it alone, and you did it alone.
how true this happens, that so many times the big industries get credit. I don't need to mention any of the names, but they get credit for these great things that they developed, whether in chemistry or laboratory, plastics or developments. And it's nearly always, not always, but nearly always some guy working in his garage or in a basement or something like that. The Wright brothers had nobody sponsoring him. Eli Whitney had nobody sponsoring him. Or Westinghouse making the air brakes. He did all this by himself. And this is just a few of the thousands of developments have been done by little guys in their backyard or in their kitchen. Goodrich, or Goodyear rather, Charles Goodyear, developing the vulcanizing of rubber. And he did it in his kitchen. Developed the whole industry of rubber.
I think motivation in research is very important. John did not mention that he and his wife Mary had been married 7 years before Mary became pregnant. And it wasn't that they wanted to wait to have children. They wanted to have children all along, and they were delighted finally when Mary became pregnant. And then Casey came along with the meningomyelocele, the paraplegia, and then hydrocephalus. So I think that a father who has waited 7 years for a child has far more motivation than other people who have not been so frustrated in trying to become a father. Is this true, John?
That's very true. I have a picture here of Mary, Casey's mother, and myself, and Casey when he's about 3 or 4 years old. I'm not sure exactly, but about that age. But he lived 5 years, but that 30-minute cardiac arrest he occurred before I had my valve developed, caused irreparable damage. The brain doesn't recuperate apparently or restore itself, and he was subject to convulsions and seizures for all this whole period of almost 5 years that he lived. And during one of those episodes, when he was almost 5 years old, his upchucked stomach contents went into his airways and clogged his airways, and he suffocated. This, of course, only takes a few minutes for this to occur, and we tried to revive him, but it didn't occur. So
I feel particularly honored that John brought his son Casey to see me when I was practicing neurological surgery in St. Petersburg, and I actually saw Casey during the time when he had basically arrested hydrocephalus thanks to his father's valve. I particularly feel privileged to have met Dr. Walter Dandy Sr. because his son, Walter Dandy Jr., was a classmate of mine at Johns Hopkins Medical School, and I always treasured the fact that I did have an opportunity to meet him. And I also feel very fortunate that I had an opportunity to meet Casey because of his father's tremendous devotion to his child, that his father was able to accomplish what neurological surgeons had not been able to accomplish. And John, I appreciate the fact that you brought Casey for me to see.
Yeah. Well, it was wonderful for me to be able to come visit my parents and know someone were there like yourself. They had the heart and the feeling and experience to take care of them when we needed them. But you mentioned that the neurosurgeons or other surgical people weren't able to manage this thing. But your world is so complicated and dedicated in medicine, you don't have time to fool around with hydraulics and mechanical things like that. And that's where my experience had been. I'd worked in hydraulics and had some experience in that sort of thing.
In fact, you mentioned this, John, about your own background, and I'm aware of something about the background of neurological surgeons. It's a very demanding field, and because we focus so much on medicine, and particularly on the nervous system, that we are somewhat short-sighted when it comes to other aspects of life. And tell us something about your own background, that you had a background that you could do this. Obviously, motivation is very important, and yet there are many other fathers over the world who had the motivation. They saw their children dying of hydrocephalus, and yet they were not able to do anything about it. And how is it that you had the background that you could do something about it? So will you tell us something about your own background?
Well, I guess I'm a gadgeteer from way back. I was never satisfied with things the way they are. I always try to improve things the best I could anyway, the things I'm aware of. And I was a lousy student in high school, barely squeaked through. I was always daydreaming, but I was always gadgeteering and making things. I made my first little sailboat when I was about 11 or 12 years old, a little pram, and then when I was about 13 or 14, I was able to, by cutting lawns and that sort of thing, I got enough money to buy a small gasoline engine for $15, and I made a little motorboat. Later on, made it a little bit larger using the same engine. And I've always been interested in cars and mechanical things. I made a lot of my own tools in my own basement, little tiny handmade lathe to turn wood particles when I wanted it. And so I'm kind of gadgeteer-minded, always have been, and not the scholar. But when I've had my own business several times. I had a service station in Winona, New Jersey. And I've been servicing automobiles and washing them and greasing them and that sort of thing. And then I took an apprenticeship application with the Ciccone Vacuum Oil Company in Paulsboro, New Jersey. They had, I think, 13 or 14 openings for apprenticeships at Paulsboro in their works refinery. And I took the competitive examination along with 424 others, and I got second highest score on that because it was purely a mechanical type of a test. It wasn't a type of memorizing formulas in chemistry or so on. And I was able to choose my own training course. So I took the automotive machinist apprenticeship, which gave me a concentrated machine shop apprenticeship, electrical, plumbing, welding, electric shop, that sort of thing. So I had a very rounded machine shop and general practice training. And then I worked in their research laboratory, which I dearly loved, working on all sorts of fuel and gasoline testing. We weren't testing engines, but we were using engines for the test means, road test work, and they had a suggestion system there that was very good, and I made more money, I think, on suggestions of how to modify the equipment and to record things, working with the engineers, the smart guys. I made more money than I did with salary. And at that time, while I was in the middle of that training course, I was drafted in the Army in 1941, and spent 5 years in the Army, and I was a crew chief in a reconnaissance unit. We had light tanks and armored cars, motorcycles, jeeps, of course. And we served and went to England first, and then 18 months in North Africa and Sicily, Italy, southern France, and southern Germany when the war ended. And when I came back, I went back to the apprenticeship training again and finished that up, and I continued working there until about 1955, and then I had several small jobs. And then I went to Yale and Town, a company that make the builder's hardware, the door closers and the door locks, and that's quite a famous company for that, the headquarters in Stamford, Connecticut. I worked in a research laboratory as a technician and testing of materials, and a lot of it was hydraulic equipment, because the door closers are hydraulically operated, most of them, not the little cheap little spring pull job, just a screen door screen, but the ones that work, the big doors, like every hospital and hotel and business in the world has door closures on them, and most of them are Yale and Town material. And they had problems with them, and it was analyzing the stresses within the unit, sometimes why they would fail. And I got familiar with hydraulics in that way, and the forklift trucks. And I noticed that a tubing would never split crosswise, always axially with the layer of flow. The tubing would burst open when it would burst under high pressure. And this sort of thing stuck in my mind, I guess, Casey's problem presented itself by trying to make some kind of a valve that would open and close with internal pressure. And then seeing the nurse irrigating this IV made me think of, well, could we make that slit that puncture a little bit more of a slit until it opened, and then it would close again. But using natural rubber, it would not pass the autoclave test, nor any of the normal plastics would. They would shrink on heating. I had to make my own autoclave. I didn't have any money these days. I had made a steel plate and a piece of pipe on it with a screw cap on it and a pressure gauge, and I would suspend these little tiny pieces in the little grid to hold them in the top, and they were subject to the steam at the pressures that you normally use in an autoclave and for the period of time necessary. So I could test them on my kitchen stove at home with this simple little device. And the natural rubber, after it was heated, it would open up and it wouldn't close it completely, nor did the plastics. So that's the reason I had to find something else that would work. And in that dramatic, frantic 3 weeks, that's when I bumped into the silicone, Silastic, made by Dow Corning Corporation. And that was how I got involved with that, and the rest of it you know about.
Well, basically, you had a lot of experience in research laboratories,
yes.
Which, of course, many neurosurgeons have not had the advantage of. You mentioned previously about some work being done in California on dogs, but as I recall, you actually had inserted or developed valves, competent one-way valves to go in humans several years before anyone else developed such a valve for a human. Isn't this true?
Yes, that's correct, yeah. Yeah, the news item that came over the Associated Press, I think it was Associated Press or maybe United Press, told me of a dog of the year. I don't remember its name, Rita or something like that, and this was the work of Dr. Robert Pudens doing it. They had given this dog an award for being the subject of early experimentation. I don't know how many others have been used, but this dog had survived using a catheter, ventricular atrial catheter system, and it was living, and they artificially introduced hydrocephalus, I guess, with kaolin is what I think what they usually use, and this sort of thing. And that, but that news report was dated, I think, late in July of '57, or maybe a spring of '58. But that was just a dog. They still hadn't used it in a human, so it probably was quite some time later before anybody had nerve enough or got the permission to use this thing. But in my case, I was desperate. I had to get something done. In fact, one night this terrible ordeal was going on with Casey trying to find something, and we watched Ed Murrow's show, Person to Person. He was interviewing Vannevar Bush, the famous physicist who was vice president of MIT, and Murrow had asked him, do you work on any small items? Are your projects all big ones like the atomic bomb project? And Dr. Vannevar Bush said, oh yes, I worked on small ones. He pulled a drawer open and pulled out a little device in his hand. He said, there's a little valve we're working on to probably will help the neurosurgeon with a very difficult neurosurgical problem. And my wife, Mary, said, oh, that's a valve, that's it. You must go call him, get in touch with him right away. I said, well, it may be so, but I'm sure what I'm doing is right and it's going to work. And I never followed through on Mary's suggestion. I just continued on with what I was doing because I felt sure that this would make a one-way valve and a little modest resistance to flow, which was, at that time, was required, and it still is, of course, in varying amounts. But that was part of the history of how I happened to get in and how I know about Dr. Pudenz's work. But I have great respect for Dr. Pudenz. I think he's a terrific guy.
But basically, the MIT valve never went anyplace because it was not a competent valve.
That's right.
It
was a little magnet and an iron ball, plated iron ball, and the magnet would hold the ball against its seat, and then the pressure would push it up and lift it off of its seat, and then the flow would occur. But the magnet was holding the ball against the seat.
John mentioned previously that the early operations using a valve for hydrocephalus were usually ventriculovenous shunts. Later we called them ventriculoatrial shunt, basically from the ventricle into the atrium of the heart. And this is what I did for many years, and there were problems because if you did the shunt operation on a 1-month-old baby, obviously the baby would grow a great deal and would outgrow the shunts, so it was necessary to revise the shunts. And I remember many times using the right internal jugular vein to feed the catheter into the heart, and then that would plug up and I would go over to the left side. It was much more difficult feeding the venous catheter down the left jugular vein into the heart because there were a lot more turns to make. John developed a flexible tip catheter, atrial catheter, that had a 3-centimeter flimsy tip on it, and I found that that helped a great deal in feeding the catheter, particularly down the left jugular vein, because it would flow with the blood. And it was also less irritating toward on the wall of the atrium, less apt to get anorrhythmia. Later on, most of us switched to ventriculovenous shunts because one could coil up more ventriculoperitoneal shunts, yes, ventriculoperitoneal shunts, because it was possible to coil up a longer length of tube into the peritoneal cavity. One could not coil up an extra length of tube into the atrium because if the tube went through the AV valve in the heart, the valve would not function well and it would squeeze on the tubing. So the ventriculoperitoneal catheters generally replace the ventriculovenous catheters. Early in the valve type of operation for hydrocephalus, there was a problem in many areas with infections. In some places, in some centers, the infection rate was as high as 30% because this was a foreign body, and infection tends to localize around foreign bodies, just like it does around a damaged heart valve. One problem was the way we prepped the skin at that time. Back in the 1930s and 40s, the skin was prepped with iodine, which is bactericidal. In the 1950s, we switched over to a bacteriostatic type of skin prep, which was not bactericidal, and I think this is the reason we had so many infections with the valves in the 1950s and 60s. Yeah. After surgeons switched back to an iodine prep, bactericidal prep, the infection rate went way down. So in most places in the world now, the infection rate with vowels is very low. There is a problem, though. I have seen people who have had vowels for 20 years who have developed an infection where they have had a transient septicemia. So most neurosurgeons now advise people with vowels or the parents of children with vowels to have prophylactic antibiotics when they're going to have dental work done or any surgical procedure where the skin is open to prevent an infection. Again, it's very similar to the advice we give somebody who has a scarred heart valve. So I would say that our success rate has greatly improved with the substitution of ventriculoperitoneal shunts and also with improved skin preps. So now it's not only children that are having this surgery, but also adults. We used to not recognize that adults had hydrocephalus, where their head could not enlarge as it does in an infant, but the same thing happens to the brain. The brain is thinned out, and they develop the so-called triad of normal pressure hydrocephalus. Basically, they start having trouble walking, they tend to stagger, then they develop mental deterioration, and finally the end triad is incontinence of urine. I have had patients myself who had been transferred from a nursing home in the fetal position, absolute vegetables, and have had a bowel put in, and within 12 hours the person is talking out of the fetal position, and within 24 hours walking around. I had a person who was a brilliant engineer who was such a person transferred from a nursing home. I did surgery using one of John's vowels, and after that he became a brilliant person again, had a large sailboat, sailed all the way around the world. He is in the Sigma Psi honorary scientific fraternity with me, and I see him frequently at Sigma Psi meetings, and it's a real pleasure to see someone do so well. As most neurosurgeons know, there are many frustrations in neurosurgery. I have not done a very good job with people who have had glioblastoma. I find such cases very frustrating, and it is very nice to see both children and adults with hydrocephalus do well. It's really a thrill to me. John, you've done a lot for neurosurgeons in the United States and Canada, but I think many people don't realize how much you've done for international neurological surgery. You're a very modest person, and you don't like to take credit for really what you really deserve credit for. But I happen to know myself that you have traveled over the world. I think you have been to Europe at least 100 times. You've been to every continent except Antarctica, and I'm not familiar that anyone is born in Antarctica with hydrocephalus. But wherever people are born with hydrocephalus or develop hydrocephalus as an adult, you have gone, you have educated neurological surgeons about competent vowels, and you have gone to third world countries, and where people could not afford the vowels, you have donated the vowels yourself without any charge, giving the vowels to neurological surgeons or pediatric surgeons, or in some third world countries, general surgeons who had to do neurosurgery in order to help these people help their own people. And I would certainly like to express our appreciation as a neurological surgeon for what you have done with international neurological surgery. And can you elaborate somewhat upon your travels and what you have done in international neurosurgery?
Well, one thing I'd like to make a comment on is what you're referring to there is the biggest compliment I think I've ever received, and the biggest thrill to me that sticks with me constantly is that one neurosurgeon, I don't remember who it was, told me that, thank goodness, at least I have something to help the patient and the parents when I see a baby coming in with a big head. He said, it used to be that I'd want to hide under my desk. And he said, now I can at least face him and talk. We have a pretty good treatment for him. And to me, that stuck more in my mind than anything else, that one little statement. But in my travels, it's true, I've been asked to lecture in many places to neurosurgeons that are just attempting this thing. It was fascinating to me that I've been able to be, as a layman, to be able to help the mechanical understanding of it to make them be more successful when they decide to do the procedure. And I've gone to many, many countries, and it's been a real thrill. England was the first country that I was involved with, and I'm associated with a group over there called the Society for Research into Hydrocephalus and Spina Bifida, and they made me, through their organization, they arranged to have an honorary Doctor of Science degree bestowed on me from the University of Sheffield, England. And I'm real thrilled about that, because for a layman to be given such an honor, it's really a milestone in my life. And
John, I notice your tie here.
Yeah, that's it.
This is a blue tie, but it has the ventricular system on the tie. Both lateral ventricles, the temporal horns, the third ventricle, the aqueductus sylvius, and the fourth ventricle. And there are many of these ventricular systems on the tie. And I'm happy to say that the ventricular systems are of normal size. If this is a ventricular system from someone with hydrocephalus, the valve is working very well, because the ventricles now are of normal size.
And the little scroll-like there is the letters of the Society for Research into Hydrocephalus and Spina Bifida. So it's but it's quite they're celebrating their 32nd year, I think it's 32nd year, this year in Hartford, Connecticut. Dr. Jim Banta he's an orthopedic surgeon, is the host of the meeting, and that's in end of June, into the first part of July.
As I recall, you have attended most of the meetings,
yes,
haven't
I've
you?
only missed 2 of them in 32 years.
Very good. John, most neurological surgeons realize what you have done in the field of hydrocephalus, but I think most neurological surgeons do not realize what other accomplishments you have made in the broad field of medicine. In fact, I had not even known myself, in spite of the fact that I've known you for the past 37 years and consider you a friend for 37 years. Many of these I didn't even know myself. In fact, I just found out today that many years ago, John suggested to an ophthalmologist that a plastic lens be made to replace the thick cataract glasses, basically inserting the lens into the eye where the lens normally is, and do away with the thick glasses, because his own mother had had cataract surgery back in the 1940s and had these very large glasses that looked like the bottom of Coke bottles, and where the person had to stay in bed for about 5 to 10 days without moving their heads. And John suggested to this ophthalmologist that he make plastic lenses to be inserted in the eyes. Unfortunately, the ophthalmologist did not pick up on that, and if the ophthalmologist had taken John's suggestion, people would have had intraocular lenses long before they really did. And John became interested in organ transplantation. And I would like you to describe some of your research in other fields of medicine.
Yeah, well, there's been, I became involved with the Artificial Internal Organ Society, and I was a member of it for about 10 or 12 years. And some of my very first meetings were involved with, there was a lot of talk about artificial hearts, heart valves, artificial heart valves, and not just transplants. And some of the valves there were causing a great deal of hemolysis or damage to the red blood cells, and it seemed to me that there'd be a better way of doing that. And I spoke to a cardiac surgeon who happened to be from Pittsburgh, and I said, I think we could make a better valve. And he said, well, how could you do that? The one that was popular at that time was causing some long after effects with this hemolysis. They're getting embolisms, systemic embolisms. So I suggested making a ball valve that would not just a ball hitting on a seat, dropping down like that each time and causing a whole big wide rim of damage to the red blood cells, to make one that a ball would go exactly halfway in the opening as an occlusion. And I have one of the little valves here. My idea of the valve was one like this, that would have this ball that would occlude the opening and be caught by these little fingers on the bottom, so that made it a one-way valve. And this eliminated or virtually eliminated the damage to the red blood cells. And this, unfortunately, I made 3 of these different sizes for this doctor in Pittsburgh. And I kind of lost track of him. I was busy with other things. And I tried to contact them at the hospital to see how they were doing. They were being put in dogs to evaluate them, and I suppose they did better than any of us had hoped. Now, for one thing, a dog's clotting mechanism is about 5 times as strong as a human, so that if it survived in a dog, it meant that it's a pretty good unit system. But I lost track of them, and I had quite a few, well, maybe a year later, many months anyway, we got orders from Cutter Laboratories that they wanted these round balls, and I said, my gosh, that's what they want them, because no one else knew how to make the balls so spherically as correct as that, because when a molded piece like that is made, it cannot have any fissures in it or dimples or abrasion marks on it at all. It's got to be perfectly complete as it's molded, and this is quite a trick, believe me. It's not, most any molded part you see will have a parting line where the mold comes apart, or a little dimple where the injection of the material that's being put in it, regardless of what kind of a plastic it is. But these balls had to be molded just right. When you take them out of the mold, it had to be perfect. There's no chance of correcting it or grinding it or polishing it. You can't do that with silicone. It doesn't work. So for a long time, this was the valve of choice by many of the big names like Dr. Cooley and DeBakey, yeah, they were promoting this valve for a long time, but it was all done by Cutter Laboratories, and I didn't even make a nickel out of that deal. But I'm glad that it was helpful to somebody anyway for a while. There are other valves that have superseded that. One of them that it's by coincidence or a design or a stolen design. I designed one in 1958 for a doctor in Kentucky. That was 2 leaflets that would turn and open up so that the blood would pass on all the sides without having any static pools of blood, which was very desirable. That's one just exactly like I had designed in 1958 is what's being sold today as the St. Jude valve. It's the most popular valve that's used today. In getting involved with those types of things, we did a lot with artificial organ organization with kidney dialysis work, the arteriovenous shunts, and a little roller pump that was bilateral that would administer protamine and heparin. The heparin, as the blood was coming out of the body before it went through the dialysis unit to so-called cleanse the blood, and then before it went back to the patient, they'd administer heparin at the same rate. And if they speeded up the blood flow, they wanted to do it proportionally. So we made one little bilateral roller pump, and it did this, and this was a very big help to the people involved with kidney dialysis. And another item we made was an artificial heart assist device. This unit was a compressible and distensible fat section here that was done to reduce the load on a failing heart. And this was put in the descending aorta. They would cut it and put the descending part into where my finger's going, and then the part that was cut off was attached onto this. And this would pulse, counter pulse with the heart, so that it would reduce the load on the heart. That was the idea of it. And I never did hear the final results of it. It hadn't been used much, but it was done by Dr. Kantorowicz in New York, who was very active in that type of thing. But you can see the complications of making that thing. Anybody that's ever done any molding to get that piece, the inner piece has to be molded, and you melt that out. It's made of a low temperature metal called Ceralow, and after it's molded, and then outside and inside mold, then you take this out and put it in the oven, and the inner part is melted out. But that inner piece of the mold has to be polished like glass. It's got to be perfect. There's no flaws, and outside doesn't matter. But the inside has to be absolutely smooth, or blood would hang up on it. And these are some of the types of things. And then one of my biggest challenges was with the artificial heart itself. There are a lot of people who worked on it. Dr. Kolff at the Cleveland Clinic was the head of their artificial organs department, had done a lot of work on this sort of thing, and a wonderful person he is and dedicated to this work. But their team had achieved 17 hours on a dog or a calf or maybe a pig. I'm not sure which animal was used, but it was 17 hours duration of keeping the animal alive with an artificial heart. And I had a lot of talks with Dr. Kolff, and we came up with an improved design on it, which I think was anyway. And I did the design work and had our men make the thing. And I supplied to the first ones to Dr. Frank Hastings, who's not living now, but he was in Harlan, Kentucky. And he put it in a dog. I used to go there on the weekends. I'd leave on a Friday night and fly down to Lexington or Knoxville, and they'd come meet me in a car and drive over to this little hospital, and they had a couple of garages in the back where he had this little animal laboratory, and he could operate on dogs. And of course, he was always selecting these big, broad-chested dogs, a lot easier to work on. And I'd help him, and we'd anesthetize the dog, and I learned a lot about surgery from this just by helping him on his Saturdays and Sundays off, and sometimes until late at night. And I stayed at a motel across the street. This is all, I never get paid for it. He wasn't getting paid for it. It was just a love of trying to do something in the way of an artificial heart. And one Sunday morning, he called me, and he said, I know it's bothering you. He said it was about 7 or 8 o'clock on a Sunday morning. He said, John, he said, but we've got 36 hours on this dog, and he's still alive. And that was more than doubling what was ever done before by anybody else. And of course, he had written a paper on it, and his boss, the chief of surgery, was Dr. Potter. And this is, may I show this thing? This is a award we received at a demonstration at the American College of Surgeons meeting, where this heart was on exhibition.
I might say this was in 1960, 34 years
1960,
ago,
yeah.
at an exhibit at the American College of Surgeons. So I think it's quite obvious from this award that John was one of the first scientists in the United States to work on artificial hearts. In fact, as I recall, you made about, what, 55 artificial hearts?
Well, I thought it was up, it actually was 67. I got the list recently, and where we sent them all over the world to any of the groups that were doing this type of research. They wanted to have one common factor, and this was the best artificial heart. And certainly it was as good as this Jarvik heart that there was a lot of publicity a few years ago. But we didn't have the money to spend in that. The driving mechanism was very, very complicated. And of course, the thing about it, I've often wondered, why do they insist on placing it inside the body? It's a mechanical device, and it's subject to failure. Have it outside, have some conduits through the chest, and that's not too big a deal to have that. Today, we have ways of controlling infection going through the chest. It's not like going into the brain. And if something fails, you can change it quickly or so on. But if it's inside the guy's chest, bye-bye.
As I mentioned before, John could have speeded up the development of ophthalmology by many years if ophthalmologists had listened to him. I think if he had had the sufficient financial backing 35 years ago, we probably would have a functioning artificial heart at the present time.
I would think so.
But the problem then was a matter of funding.
Yeah.
As John mentioned, he was working with a surgeon in sort of the backwoods area, and they were doing this on their own,
Yes.
really without outside funding. John has been very astute on where to devote his time. Someone suggested many years ago that he start making celastic artificial breasts. And John was smart enough to say, no, I will not make celastic breasts. And John is very happy now that he did not make celastic breasts. Would you comment on that,
Yes,
John?
that's right. It seemed to me that it was a luxury operation. I think there's too much emphasis on the breast size and development. I thought it was ridiculous, and I just don't believe that any of those things would have an internal gel. Now, if it could be made in pure silicone, but it'd be too rigid and too heavy. But to make them the way they were, I just couldn't. I didn't accept that. Now Dow Corning wanted me to make these for them, and also Mr. Peter Rickham in Liverpool, who was a pediatric surgeon at that time. I think he's not living today, but he wanted me to make artificial testicles for boys that had, for some reason, I don't know why, or born without them, atrophy, or weren't born with them. And they would put these in. They said the children would be self-conscious in the shower. I said, that's ridiculous. But he wanted me to make small ones that I could inject gel in, the silicone gel, and enlarge them as they grew, so they wouldn't be conspicuously caught without balls. But I just couldn't understand that. I didn't agree with it. And I never did it, fortunately. I was more concerned about something really serious stuff.
I think you have devoted your time to what has been very important. You have not mentioned several other things I know you're involved with, and that's artificial tendons.
Yes.
And for hands, is that correct?
Yes, that's correct, yeah. We did this with Dr. Jim Hunter at Jefferson at the Hand Rehabilitation Center there, and then we started this work about, I guess, around 1978 or 79, and started with just a passive tendon. It was just a piece put in, laid in there, and it's kind of sutured to the distal phalanx, and the other end was free to move, and the body would develop a pseudo, is that correct, pseudo sheath over the thing?
Yes.
And then in time, I think perhaps 3 months, they would use a splinter of a leg graft, a leg tendon, or the adjacent finger, and they would pull it through and pull the artificial one out and then join that up. And these people were regaining function. Of course, the most important part is to get the forefinger and thumb. They could hold a can of beer with that, or a cigarette or something like that. And but then it went on further, and now there's active tendons that are permanently implanted with a little metal attachment into the distal phalanx, and it's intertwined to the tendon. That's real clever, because you know the tendon pulling on an artificial device sooner or later would pull through and cut. But Hunter has worked a way to do that, and he has quite many patients with this active artificial tendon, and it's going. We're selling them all over the world. They were when I had my own company.
Very good. Also understand you worked on artificial bladders.
Yes. Well, that's a sad story to me, because in back in around 1958 or 59, when I was first starting in, this is after a few years of this work, there's a Dr. Kohler, Peter Kohler, who was German-born guy, very nice, as a resident in urology at the University of Pennsylvania, wanted to develop an artificial bladder, and it's quite an interesting story. So we made several of them, and the dogs would destroy themselves by getting a hold of this thing sticking out, and they'd pull it out. And of course, they killed themselves, but they knew that piece didn't belong there, and they'd get a hold of it and pull it out of their gut. And I said, well, put a big wide collar on their neck, and then they can't reach it. And that worked. So the dog, we put one in, it's ureter valve, vesical ureteral valves, and a bladder. And that dog lived 2 years with normal kidneys and normal bladders, normal ureters, with this artificial bladder for 2 years. And at that time, he was called into the Army I guess I worked at some kind of a deal, that is, with the military to serve his time in the Army, as help paying for his schooling and so on. And when he came out, he was married and had 2 children, and he wasn't interested in doing any development work now, experimental stuff. He wanted to make some money and feed his family. And I can understand that too. But it's sad that that died, that whole thing died. I don't even have that original battery. I did have a copy of it. I made several of them, because the first ones they had difficulty implanting it and hooking up their ureters to make sure that they didn't slough off and fracture. But finally, they got this thing, one of them that lasted 2 years, and it would seem to me that it was pretty encouraging. That it should have gone further with it, unfortunately.
I think this illustrates some of the problems in research, in that if sufficient funding is put into research at the right time
And the right people.
and the right people, that there can be tremendous advances in medicine. Unfortunately, many projects have not been properly funded to the right individuals, and it has slowed down medical progress. John, I know you're a very modest person, and you don't like to blow your own horn, but I am aware of many of your accomplishments. You mentioned that you have received a honorary Doctor of Science degree, as I recall, from Sheffield, England, on their 100th anniversary.
That's right.
And I think this is quite an honor that a university, an internationally known university, on their 100th anniversary bestowed this honor on you. You also mentioned about your exhibit at the American College of Surgeons. I have several letters here from a Dr. Willem Clough, and in which he was in at University of Utah, recommended you for several additional awards. So if I can drag out from you some of your honors, I would appreciate if you would go ahead and tell us about some of your honors.
No, the local organizations like the Rotary and Kiwanis and Lions, they've given me some honors, that sort of thing. And I was in the retarded Pennsylvania chapter of Retarded Children, and also this European Society for Pediatric Neurosurgeons elected me a member of that. I guess it was about 10 years ago, 12 years ago. I was the only non-professional and the only non-European in this organization. Not in your league at all, but it was quite an honor. It happened in Italy at one of their meetings, and I've kept active in it as much as I could. I haven't been to the last 2 meetings, but it's been quite an interesting episode in my life to have these. But you know, the thing that you spoke of, the advancements in medicine, one of the tragic things that's occurring right now, the FDA is in the process of instituting some fees for development of new products. And if it's a very, very minor change and requires what they call a 510K proposal, which is sort of a cursory examination of a thing, if it's just a change in dimension, slight change in dimension, and not really changing its function, it needs a minor approval before you can do it and sell it. That's for all the manufacturers. It's Codman and Cordis and all the rest of them, Johnson & Johnson. But that would cost about $5,000 or $6,000 just to get this little minor thing. But if it's a major development, something new that really could be effective and helpful, it has to go through pre-market approval, PMA they call it, and clinical trials, which usually requires maybe 2 or 3 or 4 university series of maybe 10 each, and 1 year follow-up, which is all kind of expensive. Now you got to develop the device and get 4 universities to sponsor, to go ahead with this project and develop it, And they're all at risk doing these things because it's kind of risky work. It's experimental work. And that, just to make the application for that cost $63,000 to get that permission to even start doing that.
I'm frankly glad that you and Thomas Edison came along at the time you did, because I'm afraid we would not have any effective electric light bulb if
Yes.
Thomas Edison had to work in the climate we had now with all the federal approvals. As you're probably aware, neurological surgeons are very concerned about the encroachment upon government on the practice of medicine, and you're obviously concerned about the encroachment of government on scientific research. And so we're in the same field as
And
the same concerns.
I have started a patent approach on a type of valve that would be automatically compensating, because there are some new valves on the market now. Other companies have made them that are adjustable from external transcutaneous adjustments, but they're still only one pressure valve, and it doesn't take care of the horizontal vertical change in interventricular pressure. And I have a valve that would do that, but it's I couldn't afford to get it done.
I was going to ask you, John, about the future of hydrocephalus, the future of vowels, and in a larger sense, the future of medicine as far as new developments in medicine. And what do you really think the future holds?
Well, when you're thinking of what I've just said about the difficulty of getting it through approvals through the FDA, it makes it extremely difficult, and it certainly is going to retard progress. It's a common knowledge today that if aspirins were not already in existence, you probably wouldn't be able to get an approval on it. It's too dangerous, too toxic. So you never. But it's typical of what's happening today. The security from cradle to grave is so important to so many of the politicians to get their votes out and that sort of thing. It's going to really hurt progress because the average lay person doesn't understand this. Period.
John, appreciate it very much. And on behalf of neurological surgeons all over the world, I would like to express our deep appreciation for you for helping thousands of neurological surgeons, helping hundreds of thousands of patients over the world to have not only more quantity of life, but also quality of life. So, John, thank you very much. And you've
thank
been a
you
friend for many years.
Yeah,
I appreciate what you've done for my patients.
I'm grateful to you, all you and your profession.
Thank you.